This educational video will explain and demonstrate the procedure of administration of surfactant by minimally invasive surfactant technique. I perform this procedure by using a thin infant feeding tube as the conduit for administering surfactant in this particular baby. This is done without the use of Magill's forceps and avoiding the need for sedation or narcotics. Alright, herein we have a 32 weeks preterm baby who is currently 12 hours of life and who is being administered the surfactant curative by minimally invasive surfactant technique using a thin feeding tube catheter. Missed by using thin feeding tube is the less invasive surfactant administration, that is LISA, L-I-S-A. This baby had been started on nasal CPAP since birth by an SLE flow driver machine. The baby had been cared for in giraffe incubator. It's a very good incubator that maintains the thermoregulation of these babies even if all the side doors are open fully. Means there is a thermocurtain. This baby's FiO2 requirements whilst on CPAP had been creeping up and it went up to 50% and now currently it is 45%. As per the unit policy, escalation from nasal CPAP support to the next step, that is surfactant administration, is done at FiO2, fractional inspiration of oxygen, cut off of 0.3 to 0.4, in other words 30% to 40%. In this baby we have oxygen requirement which has exceeded 40% or 0.4, so I am going to give surfactant. To introduce about this minimally invasive surfactant technique, the basic and essential difference from the earlier INSURE technique is that the baby is continued on this non-invasive support, that is the nasal CPAP, all throughout. Now, in this baby, I am giving curative 200 mg per kilo, the standard recommended dose. I am using 3 vials of 3 ml vials. 3 ml vials of curative, total of 6 ml. 6 ml of curative equals 6 into 80 for 80 milligram. In this baby, the correct dose by the 8 is 400 milligram, but we err on the higher side of the dose when we come to surfactant, given its entire safety profile. So we have the curative in the syringe. See that substance, curative, and the conduit I am using is 6 French infant feeding tube. To be specific, the brand used is Microtech. The baby is brought to the comfortable position for continuing the CPAP and for the procedure to be performed without the loss of thermoregulatory support. There is a syringe with air and there is a syringe with curative, and there are a few syringes as a standby. There is suction apparatus ready, and there is a bag and mask and intubation tray for any eventualities lest it may happen. So, there is a feeding tube to check the reflux of surfactant at the end of the procedure. So, along with this we need laryngoscope with correct size of blades, pair of gloves, 2 monitors and a team to assist myself. I don't require a Magill's forceps for threading the feeding tube as I have gained expertise in this technique over the last 2 years. The procedure is performed as if you are doing a normal intubation. Visualize the glottis by indirect laryngoscope. The V-shaped cartilaginous vocal cord will be moving during the baby's breathing. The stomach should be emptied before the procedure. This is important because at the end of the procedure, we have to confirm that there is no significant exit of surfactant due to reflux into the tummy or stomach. While doing the procedure, no additional tubes shall be there in order to avoid confusion. So, the preparation of the baby before giving surfactant in this instance will be emptying the stomach, the oral feeding tube will be removed, and I visualize the glottis and attempt to thread the infant feeding tube across the glottis. The infant feeding tube material is very important. It should not be very flexible and malleable, because then it cannot be guided into the glottis. It cannot be so rigid that it induces the airway. It has to be of particular strength that it is maneuverable across the glottis easily and stays there until we finish the procedure. From my practical experience, I find this particular brand, Microtech infant feeding tube, fits and is very useful for doing less invasive surfactant administration. That is missed by using the thin infant feeding tube. The baby should be on continuous monitoring, and the baby should be put on 2 monitors continuously, as even if one monitor is not picking the signals, other monitor will be there to the monitor. Saturation monitoring, heart rate and pulse rate monitoring is very essential to the procedure and after the procedure as well. It is important to make sure that the feeding tube is in the correct location, means the feeding tube, once it passes the glottis, is in the correct location, not entering on lung. Preferably, it should be in the position just above the carina, as in a normal ATT, so to deliver the surfactant both sides equally. This is ensured by checking, by flushing of air and confirming equal air entry on either side, as if the normal procedure of checking the position of an ATT, as you will do in an intubated baby. Full stop. During the procedure, a close eye is kept on the readings of the multi-channel monitors. In fact, one of the team members has to relay the pulse oximeter reading to the clinician who is performing the procedure. In this situation, it's me. The saturation should not be allowed to drop below 80 to 85, and if that happens, the procedure should be interrupted and be brought back to normoxemia before attempting the procedure. Now, Curasaf is administered fast after confirming the position of the infant feeding tube, as if you will administer through an endotracheal tube. Curasaf is given rapidly, followed by adequate aliquots of air in 10 ml syringes. This air injection is just to push the Curasaf down to the distal airways, the alveolar sacs. The lung volume of the baby is around 20 to 30 ml per kilo, so I will inject around 10 ml aliquot and another aliquot of air quite fast, because the lung is filled with air and there is no harm in injecting air into the lungs. But make sure you are not blasting the air into the lungs. As if a baby takes normal breathing, please inject the air. This is to push the Curasaf into the distal airways where its action is to be there and prevent reflux as well. Once this is achieved, we remove the feeding tube catheter from the trachea. Close the mouth so that the CPAP can use the effect. Wait for some time to stabilize the baby and then transfer the baby to his normal position of nursing care, and CPAP will be continued in the usual normal position of the baby as before. And then we pass the infant feeding tube, aspirate the stomach and check for the reflux percentage of the surfactant. In this particular baby, you can see we have only very minimal reflux, which is less than 1 ml, which is hardly even 10% of the volume of the surfactant we administered. So in this, we have achieved a complete success of this procedure. This was subsequently proven by the prompt recovery of this baby post this procedure. The baby came off oxygen within 18 hours of administering Curasaf. Thanks for watching this video. This is Dr. Karthikeyan, consultant neonatologist in Dubai.